Well, good morning. I'm very happy to be here this morning, although as an aging baby boomer, I'm happy to be anywhere this morning. I think the transition from understanding the volume of chemicals that was just presented to us and the discussion of how we operate in the occupational arena is a good one. What I would like to do, based on my last 10 years of experience after having left CDC and landing in academia, is lay out for you several paradigms that will hopefully be useful. This is probably one of the most used slides that you can find on Google. It's basically when people say, what is the public health approach to something? The answer is, what are the public health approaches to something? What constitutes public health? Is there any one concept, or is it multiple concepts depending on your point of view? So it's the traditional elephant issue. So what I'm going to do today is, in order to cut down on some miscommunication, I hope, this is the Tower of Babel. Remember, it's a city in Iraq. And a miscommunication led to disaster back then. And the more communication that we can have currently, the better off we can be. So I'm going to introduce essentially 5 paradigms. One is the industrial hygiene approach. The second is the Cascade of Prevention approach. The third is to talk about surveillance in public health. The fourth is to talk about embeddedness, and the fifth is to talk about a paradigm of dose response, which is the real conundrum from a population-based effort to control toxicity. I have about 15 minutes or until I'm terminated. So let's talk about, first of all, the traditional public health approach, which is one of anticipation, recognition, evaluation, intervention, and effectiveness. And this is what is taught in industrial hygiene. And quite honestly, from an occupational health, occupational epidemiology point of view, I find it very useful. Anticipation is something like if you take a micro car, like a smart car, not to use any brand names, and you take a teenage driver and you take high speed on a highway, you have to anticipate the problem that you're going to run into. From a recognition point of view, it's sometimes we can anticipate, we just have to recognize. It's interesting, you quoted Paracelsus. I would have quoted I am going to quote Ramazzini. Ramazzini's quote from about 1710 was, "I've never visited a nunnery that has escaped the scourges of breast cancer. There must be a connection between the breast and the uterus, which escapes the detection of the prosectors," meaning dissectors. So Ramazzini, the father of occupational medicine, not only invented occupational epidemiology, cancer epidemiology, endocrinology, in just that one observation that the risk factors associated with delayed childbirth lead to adverse effects. Could not have been anticipated at that time, but was recognized, an example of recognition. Evaluation is a little bit different. Lots of tox studies showing that TCDD, tetrachlorobenzodioxin, is associated with adverse effects. The evaluation came in the 80s with NIOSH doing a cohort mortality study of about 6,000 workers highly exposed to dioxin in various occupational situations, and was able to then identify the adverse effects associated. Intervention comes from education, engineering, regulation. These are how we intervene. And evaluation comes from looking at whether what we've done has actually been effective. This is the industrial hygiene approach. It's a good, broad approach that helps us work on issues of recognition of hazards. But I want to now go on to an example in order to introduce the other paradigms. And the example I'd like to use is O-TOLUIDINE. The history here is that aniline-based dyes like benzidine have been known to have been carcinogenic, and bioassays in the 70s suggested that toluidine was much more carcinogenic than aniline, and that toluidine was actually associated with bladder cancer in animals. There were a few studies in the 70s which demonstrated that aniline was not associated with bladder cancer, but that mixed exposures of these dyes were. The exposure populations are two. One is an occupational exposure, which the National Occupational Survey in the early 80s estimated about 30,000 workers exposed to toluidine. The other is the estimate, since aniline and toluidine are in cigarette smoke, is that you're talking about tens of millions of people who are exposed to toluidine at lower levels of exposure, right? So there is some sense of anticipation that given these occupational exposures and these environmental exposures to something that is a known carcinogen in animal studies, that there may be a health effect associated with it. That brings us to 1988, when Steve Markowitz, who is an occupational physician, was working with the Oil Chemical Atomic Workers Union, visited a plant in upstate New York to give a general talk on occupational health. And workers approached him and said, is it meaningful that 7 of our cohort have bladder cancer? The answer was yes, and we should ask for an evaluation of the situation by going to the National Institute for Occupational Safety and Health, which responds to workers or managements for evaluation, a hazard evaluation situation. I was there, I was on the walkthrough. We learned very quickly from signs that were posted saying suspect carcinogen, literally signs saying that there was a suspect carcinogen, that there may really well be a problem associated with this plant, and we found out that the suspect carcinogen was toluidine. We did the incidence study, and we found for people who were exposed for 10 years that they essentially had a 30-fold risk of bladder cancer. For people who were exposed, who had a 20-year latency, there was a 20-fold risk. So there was really a problem. This was anticipated in a certain sense in that the workers in the plant were being screened by the company. It was not anticipated from essentially the sense of, had we chosen to look for the adverse effects of toluidine? The answer is no, we hadn't chosen to look for it. It came to us. It was responsive, it was reactive, it was not proactive. The effect of all of this work is sufficient evidence for carcinogenicity in humans according to IARC, and orthotoluidine is now accepted as carcinogenic. This is the way in reality it largely works. And when you think of Lynn Goldman's talk about the volume of chemicals there, you might come to the conclusion that in most instances our efforts to identify carcinogens and other hazards are reactive. We react to observations by astute observers, whether it's Ramazzini or a group of workers at a chemical plant in northern New York State, that there's a problem. We react rather than we systematically investigate. Paradigm number 2 is a little bit different than paradigm number 1, which is the industrial hygiene approach. This is really the preventive medicine approach. There's primary prevention, which is something you do before there's exposure. It's pre-market testing so that something doesn't ever get to the workplace. It's environmental controls, it's personal protective devices, it's all those kinds of things. Secondary prevention is limited solely to screening, the early detection of disease, and tertiary prevention, which has grown immensely in importance in the last 10 years, largely due to the observations of the Institute of Medicine about the number of people that die because of inadequate medical care, is the third kind of prevention. It's tertiary prevention, right? Now, if you put all of these things in a list and think about toluidine, then we could be talking about pre-market testing, substitution, elimination, environmental monitoring, et cetera, All of this is primary. All of this falls in the area, if you will, of toxicologists talking to industrial hygienists. The physicians become involved in the screening cystoscopies, et cetera, and then these are the preventive medicine clinicians, and then the true clinicians, if you will, get involved in the surgery, the compensation, and the accommodation, right? So let's go on to putting the same information into a cascade. Hematologists have cascades, so people in preventive medicine can have cascades. So the cascade in preventive medicine is that primary prevention is better than secondary, is better than tertiary. We take it as a given. Let's put all of the things in the continuum of things that we can do for prevention into a cascade, and this is how we operate in the industrial setting to reduce adverse effects. We try our best at these levels up here, and oftentimes we only find out that there's a problem down here when there's clinical care made available to 7 workers who have bladder cancer. We don't find out about it up here, we find out about it down here. Which brings us to the next paradigm, which is surveillance. Surveillance, which was really fathered by Alex Langmuir at its Centers for Disease Control in the 50s, although historically goes back into the 19th and 18th century, is a systematic effort to collect relevant data, disease, injury, hazard, and intervention, constant evaluation and dissemination to all who need to know for the purpose of prevention. That's surveillance. Then next issue is, what is a sentinel health event? And this is a concept that was developed, or paradigm that was developed at NIOSH in the 80s. A sentinel health event is an unnecessary disease or injury, disability, or untimely death, which is known to be preventable and whose occurrence serves as a warning signal that an opportunity for prevention has been missed. So we got the idea of surveillance, and we got the idea of surveillance of sentinel health events. So this again is our cascade of prevention, and just to specify that surveillance isn't in the cascade of prevention. It's not something that you do directly to reduce exposure, et cetera. But this is surveillance. This is a basic mechanism. We collect data on clinical care. Okay, there's 7 cases of bladder cancer. What does that mean when we go back to the design of the operation? What does it mean to how we ought to take care of environmental monitoring? Should we be protecting workers better from the exposure? So surveillance, essentially, the surveillance sentinel health event paradigm is the servo loop. We have to find out about things, then we have to use that information to ask, how are we doing with control of these exposures? Now, the 4th paradigm is, all of what I've said is very nice, somewhat academic, somewhat conceptual, and it's all embedded in economic, social, political, regulatory, and ethical matrix. We all have to work in this matrix. Now, the 5th and last paradigm I want to attribute to Jeffrey Rose from his book called The Strategy of Preventive Medicine. This is the distribution of systolic blood pressure in the population according to Halperin, all right? You could also say this is the distribution of toluidine in the population according to Halperin. Remember, we've got workers, 30,000 of them up here, occupational, and we got all these people here with lower levels of exposure from smoke, right, who are environmental, right? Okay. This is the clinical approach to the control of hypertension, and it's the occupational approach to the control of toluidine. We set a bright line, and we call everybody to the right of it a hypertensive, right? We see them every 2 months and treat them and whatever, and these people we reassure and tell them to go home, right? And the same, if you will, is true if you think about toluidine. Public health approach that Rose proposes is actually, yes, take care of the people at the highest exposure, but shift the population to the left, reduce exposure to everybody, for everybody. And this will have more of a complementary effect than just looking at the highest level exposure people. So let's get away from the hypothetical and let's look at the data for a second. This is the distribution of systolic hypertension in the population. And you see these folks up here with systolic pressures of greater than 180 is very small and very limited, and they're at very high risk, right? This is the relative risk. This is the distribution of blood pressure. Down here, you look at the percent of all fatal coronary heart disease that is attributable to these blood pressures. And you find out that those with blood pressures of greater than 180, while at the highest risk, attribute to actually a very small percentage of the total population effect. A lot of it is down in what we would consider the normal. The same could be true essentially about toluidine. We focus on the highest risk here, but we have to deal with the fact that most of the bladder cancer that's probably coming is coming at very low levels. So this is the clinical approach, this is the public health approach, and that is the end. Thank you.